sort of uprooted and shifted around quite a bit. And the patient population is in primary care, that is the first port of call with the GP, general practitioner, who have somatized distress. They have symptoms, physical symptoms, but nobody seems to find out what's really going on. So I hope you find it interesting. Anyway, I find it interesting. So we're going to look at the problem first. What is it about this patient population? Looking at promoting well-being and resilience in terms of the solution to the problem, which I've called the BodyMind approach. And we'll look at a second project, which has been about embedding the intervention into the NHS. So previously, medically unexplained symptoms used to be known as psychosomatic. That's what it was first known as. And then it changed in the UK to MUPS, medically unexplained physical symptom, and now it's changing again to bodily distress disorder. But most people in the NHS primary care practitioners, health practitioners, call it MUS. Patients hate it, GPs hate it, but that's what we're stuck with at the moment. So there's symptoms such as abdominal pain, chronic fatigue, fibromyalgia, IBS, you know the sorts of symptoms, pains across the chest, breathing problems, insomnia, all these sorts of problems that patients get quite chronic with, and they can't find anything wrong with them. They go for tests and they go for scans, and they keep coming back negative. And so the patient is left being told you just have to live with them, so they become more and more depressed, or they think maybe they just haven't found out what's really wrong with me. And we don't know everything, so there may be an organic cause. But up to that point, after years and years of tests and scans and blood tests and going back to the GP and pills and things, they still come back with no change. So they're persistent, they're chronic. We call it a clinical and social predicament, which means a broad spectrum of presentations in which the GP has a great difficulty in giving any kind of pathology to. So the 8 common physical complaints in 80 million physician visits in the USA, only an organic cause found for 25% of those symptoms. So that's the sort of problem we're looking at. In the UK, in 2008, this problem was £18 billion. I don't know how much that is in euros, but it's about 11% of the NHS budget. And these patients aren't being supported, they aren't being helped, and yet all this money is being spent on them. So what I thought, well, maybe we can save some money by offering them some support, so they don't need to go back to the GP, so they don't need to go to the visits to the secondary care specialists, so they don't need to have the gallbladder out and still got pain, even though everybody knew it wasn't the gallbladder, because some of these interventions they have are really quite, destructive. They actually take things out of people's bodies, and there's nothing there. So I thought maybe we could offer some support through our work in the body-mind interrelationship in order to support these patients, so they did actually have a bit of a less distress going on in their lives, so they could probably function a little bit better in their lives and maybe not be so depressed and anxious. And then again, in primary care in the UK, 10 to 50% of the 14 most common physical symptoms, 75% of all those visits, again, are medically unexplained. But just to summarise, I can justify every single one of these statements. I haven't put references for everything because there's not enough room in the references. But every single one of these statements is research. Okay, so that all of these statements are justifiable. So we know that MUS is a very, very common problem. The savings in primary care are big, but in secondary care, because of the cost of scans and so on, they're even bigger. So we can save far more money in secondary care than in primary care. But even so, in primary care, we can still save money. We can at least free up GPs to see people they feel they can help, instead of keep on seeing these patients. They're heart sick, they call them heart sick patients, that's what GPs call them, heart sick patients, or fat files, or the other word is frequent flyers, because they're there every week, and they keep writing them long letters all the time. So really what I'm saying in this is that the symptom, the physical symptom that the patient goes with to their GP is just the top 20%. You don't really see what's underneath, because they're not able to conceive of it as being anything psychological, because they've got physical symptoms. They're in pain. So they don't want to go to CBT, cognitive behaviour therapy, which has got a research base for fibromyalgia, chronic pain, chronic fatigue. They don't want to go to psychological therapy. They don't even want to go to therapy because they're in pain. They've got physical, something that's actually distressing them in their body. So they can't see the point of doing something with their mind. Because they haven't yet made that connection between body and mind. So underneath, of course, is in the unconscious, is loads and loads and loads, which is not yet risen up. So they can't see that. So what are the characteristics of these patients? 70% suffer from depression, fewer years normally in formal education. They have quite a lot of correlation between parental neglect, abuse, especially with women with pelvic pain. So gynecology, 57% are MUS, women go to gynecology. A correlation between childhood sexual abuse and pelvic pain. So gynecological consultations. A worse quality of life compared with people with an organic pathology. They have 50% more consultations. They actually have more than that in the UK because we have 11 minutes for a consultation with a GP. These patients take 33 minutes every time they go. 3 times as much. So it costs 3 times as much. I mean, every consultation is £180. Pounds. Don't know how much it is, 300 or something euros. If you costed that out, and they go every week, that's a lot of time that the GP is spending with them. No wonder they're frustrated. 50% more healthcare costs and 33% more hospitalisations. They go along to accident emergency, they've got abdominal pain and they're admitted to the hospital. Nothing wrong with them internally, but they have got some pain, probably emotional pain. Generally high levels of health anxiety, they really think they've got the big C, and then, as I say, new interventions like surgery can increase their anxiety. So they have more sick leave from work because they're having symptoms constantly. They're more likely to be unemployed because they can't work. It's comparable to medically explained symptoms in terms of physical function, or actually they're even worse, they can't drive, whereas some people with physical impairment, they can at least drive. Poor general health, mental health. Affect regulation, very poor affect regulation with this population. Affect regulation is where they can, if you can balance or homeostasis of your internal processes, so that you can actually access some of your internal resources in terms of your emotions. Alexithymia is a common word associated with, or common definition associated with this patient population, where they identify feelings as pain or feelings as symptoms. So they have a confusion between something they feel in their body and an emotion. It's confused, it's conflated. They usually have an external locus of control as well. So they're obviously very needy because they go to the GP all the time. And the history of trauma often is unfolding. The more they begin to get connected bodily, the more outpourings are around early neglect and trauma. So the emotional cost then to the patient of having no support is they have frustration, they have a great deal of fear because there's no diagnosis. And as we know, without diagnosis, you can't access services. They have a lot of anxiety, they might just have cancer or something they just haven't found yet. They always assume they're the only person that the GP cannot find a diagnosis for. Well, actually, it's quite common. So they have a lot of isolation. And they have a variety of consultations, tests and investigations, as I've said, with the negative results. Mostly, they have these feelings of isolation because their family and friends get absolutely fed up with them going on and on and on about their symptoms. So they're always complaining about their symptoms, and their family and friends are just at the end of their tether. They can't give them support anymore. So, resilience. That's Tigger. Tigger, as you know, is in Winnie the Pooh. And lots of friends, and they will get into these scrapes and they will get out of it. So they have resources, as many people do have, resources to bounce back, to deal with life and everything life throws at us. But the patient with the medically explained symptoms is so worn down by the chronic chronicity of their symptoms, they just have not got access to those inner resources. So they find it very difficult to stand on their tail and bounce, like Tigger can. What happens when we have resilience is that we can recover quite quickly and sort of get back on track. It requires an adaptation, though, an adaptation to the adverse situations, and a way of sort of living with your symptoms, I suppose, living well with your symptoms. And in the work we're doing, we're looking at the body symptoms, so we're focusing on the body symptoms as if you like a gateway into that unconscious, into that bottom of the iceberg there, into the underlying aspects that are going on. There's also a little bit of a psychoeducation, as you talk about the neurobiology of it, a little bit of understanding, and not great insights necessarily, but there will be some understanding of what triggers maybe more severe symptom of stress than at other times. So they begin to start maybe noticing a little bit more what's going on in their lives, and in noticing what's happening in that moment when they feel a little bit more of the symptom or more distress, they start to make a connection between maybe increased stress and increased pain. Start making those connections. Emotionally then, more they're able to handle stress. If they can figure out what the triggers are, they can then perhaps cope better. They can then feel better, and then they can begin to acknowledge their feelings around them. And then in terms of the relationship, obviously there's subjectivity between the facilitator and the group, but most importantly, the group themselves support each other. And it's that which all the patients say is the most supportive aspect of this work. Spiritual. Why me? What have I done? Why am I in pain all the time? This arises a lot, so people have this existential sort of questions about why is it that I'm getting this chronic fatigue? Why is it I'm getting this pain all the time? Why have I got these symptoms? What have I done to deserve this sort of thing? So the body-mind approach then incorporates all of this. I quite like this little picture because it reminds me so much of what it must feel like for some of the patients before they come. That they are in a desert really, and they've got no resources. They've got nobody giving them water. They've got nothing to sort of help and support them to grow. And yet they come to us with this little tiny bit of hope that maybe they can do it differently. So they come with this little bit of hope, and they blossom actually throughout the process of the 12 sessions. They really blossom. And because of that installation of hope, when they're referred, immediately that hope then becomes realised. And then they can begin to live much, much better, have less symptom distress, and get on with their lives. And the bad days aren't as bad anymore. So what is recovery? Recovery and resilience, very connected. Recovery is a big word in our mental health field in the UK. I suppose you've heard of it as well here. It's about feeling more in control. It's about feeling that you're moving forward rather than going in a downward spiral, which they often are at the beginning. When they go to the GP and the GP refers them, nothing there. Then they go back for another consultation, nothing there. And then they get a test, nothing there. And they go down, 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 down. What happens is they come with this little bit of hope and they start going up the spiral. So achieving a better quality of life, even though the symptoms might still be there. Often they disappear, but sometimes they remain, but then they don't affect them so much. So they feel better. So what is the recovery model? It's used widely in the UK mental health services, and as applied to patients with medically unexplained symptoms, it aims to reduce their symptom distress, including symptoms of anxiety and depression. What it does is it cultivates their different perception of their bodily experience by valuing the body and the sensory experience of the body, which they don't want to go into at all, because of course it's pain, isn't it? You just want to get rid of it. You all have pain from time to time. You don't want to go into it, you want to push it away. But by going into it, by actually, if you like, meditating on it and being absorbed in it, there can be a dispersal of it. It's quite ironic how it works. They can reflect a relatively positive adaptation despite the significant symptom phenomena as stresses, and they can foster, therefore, protective factors. These protective factors then buffer them from the negative effects of stress or leading to other bodily symptoms. Sometimes symptoms shift around, so they might have abdominal pain one week, and then they might have a headache the next. So different symptoms, skin condition one week and breathing problems the next. So even though one symptom might disappear, it transforms and metamorphizes into something else. Just a few components of recovery. Notice hopes in there. Empowerment. Peer support. individualised and person-centred. Self-direction. So every single practice that takes place in the groups, they have their own symptom in mind. It's a generic group, so it's not just for fibromyalgia or IBS, it's for a whole range of symptoms that are presented, and some of them are really weird, really weird. So in each of the practices, the patient will bear in mind their particular symptom and then work with that. They don't ever have to disclose their symptom, because some of them are quite, let's say, embarrassing. They don't want to be talking to everybody about their symptoms. So they just bear it in mind whilst they're undertaking the practice. So the practice itself is derived from dance movement therapy, particularly authentic movement, body awareness, sensory motor awareness, mindfulness. We build a lot on the mindfulness research, which is very current at the moment. In fact, we're going to embodied mindfulness now. So group work, obviously, and psychotherapy, which is the integrative form of psychotherapy, where person-centred and psychodynamic comes together. So this playing with the symptom in movement, it's playing with the symptom, allowing the symptom to move you. We do work with eyes closed, and we do work with other members of the group acting as witness. The facilitator also acts as witness. So there's a playfulness around exploring, digging down into the symptom. What is its nature? What is its purpose? And then promoting resilience, of course, then digging down, finding those inner resources, and that promotes recovery. So we're not in competition with CBT or even psychotherapy. We're saying it's not therapy. We're saying it's a symptoms group for those patients who are preoccupied with their symptoms. As I said before, they're not psychologically minded. They are, in fact, quite proactively resistant to anything that has a mental health flaw on it. So they'll come to our group and they'll stay, 91%, 94%, 97% in the three groups I can think of, attendance, which is really, really good for this patient population. So when they come to our groups, by the end, they can actually see the point of perhaps going for counselling, psychotherapy, CBT. They can sort of begin to get it in that sense. So we're sort of preparing them maybe to go on and do some further long-term work. It offers a both and, not an either or. In other words, if they want to carry on having tests and scans, they can go and have those. Actually, they don't. They don't go to their GP while they're in the group. They don't need to. They don't need to go and have tests and scans because they're learning about their symptoms. They don't need somebody else external to them because they become very dependent, of course, on the health service doing things to them. They become empowered, but they're actually beginning to learn about their symptoms themselves. As I say, it's a group format which is hugely important to the patients. It's a biopsychosocial approach, as I said, informed by neuroscience. So we've got the clinical program which lasts the first, there's an individual interview with a facilitator, that's one-to-one, where they discuss the nature of their symptoms and what brought them there, really. And then they have 12 sessions. The first 2 weeks, they have 2 sessions a week, usually Monday and Thursday, or Monday and Wednesday, or Tuesday and Thursday, something like that, just to bed them in. So the first 4 sessions, they get really bedded into the group, and then they don't want to leave anyway, because they really like each other and they really enjoy the company. They all have cups of tea afterwards. And then, after that, they do weekly sessions. So they come for a further 8 weeks after that. And then, we don't just drop them. A lot of group work, you do the group, we'll do therapy, and that's it. Bye-bye. Go and deal with it. What we do is we offer nudges. So we offer, for example, they write a letter to themselves during the group work about advice to themselves from the wise one. So the counsel they give themselves during the group work, they then write that in a letter, and then we send that to them 6 weeks post-group. It's a little nudge. We also, in session 11, and the individual consultation with the facilitator post-group, the week after the group, they design their own action plan. And in that action plan, they arrive at certain ways of being in their life. So they change something, not big things like getting divorced or anything, but they do change little things in their life that they feel they can change. So maybe their diet a little bit, or maybe go to bed an hour earlier, or maybe putting something over their eyes so they can sleep, or anything. They just make a little change, and they put that into their action plan, and then they send that, the facilitator writes a letter with that to them 6 weeks post the other letter. So that's 2 notes in 12 weeks. And then the final nudge is a text message to them saying, how are you? It's just with a question mark. And depending on how they respond to that text message, then we can offer them a self-help group or another facilitated group if we've been lucky enough to get a contract where the GPs are paying for that. So there's these nudges to keep them going for a further 3-4 months post the group experience. And then finally, we have another assessment. So they have a 6-month assessment post-group as well. They have a pre-group assessment, a post-group assessment, and then a 6-month follow-up. And I'll bore you with some pie charts about that in a minute. So there's 2 phases really, the face-to-face contact, phase 1, and then these nudges in phase 2. Oh, that's another picture. So, but it's like sometimes something rises up out of the unconscious, quite fresh and new. And that's what it's like for these patients. Suddenly something strikes them, even if it's just, I don't breathe into my abdomen, something like that. Something very bodily oriented, but comes up just like that, and they really notice it and recognise it. So that's why we call a breakthrough represented here from under the water, where the geezer rising up out of the unconscious, sparking a different way of being in themselves, a different way of seeing their body. Maybe experiencing their body, a part of their body is pleasurable for once, because maybe they've never had that experience. And therefore coping with their symptoms differently. So the embedment project was based on a pilot study I did back in 2008, wrote up in 2010. Taking account of conversion and dissociation is also presented in MES, it's another paper. It's practice-based research, so it's not pure research. We haven't got a control group, we are applying for a randomised controlled trial, but we are still collecting data and analysing the data. So the whole thing was set up with research in mind. So we've got some evidence. Albeit small numbers, we have got evidence. So when you go to the health secretary and say, we want to do this, he says, where's your evidence? We've got something to show them. We've got some kind of evidence that shows that people do get better. The NHS changes have been enormously difficult to negotiate. For example, we've got clinical commissioning groups now, so GPs commission all the services for primary and secondary care in a particular region. And they're not really financial people. They like to be with their patients, but they come out of the surgery and they sit in a meeting and they decide on what the priorities are, and then they budget for them. And they did, before April this year, they did not know even how much a scan cost. They used to write referrals all the time, send people off, put prescriptions through. They didn't even know how much it cost. Now they know how much it costs. So obviously their hairs are it's quite interesting to see their responses actually. They find it very, very difficult. But they're having a lot of training and a lot of support. They've got massive clinical support units of administrators and the old commissioners who are supporting them to make these decisions and budgets. The patient safety is up there as a priority. Health and wellbeing boards. These are boards which inform the clinical commissioning group, and they're made up of local representatives from the council, social care, lots of lay people on them. So they are sort of informing what's going on locally. So it's very much a localised service. So it's not a national health service at all. It's a local health service based on the local needs of people in that particular area. Because health is local. There's also the Care Quality Commission now has got a remit to inspect all GP businesses. So every single GP business now has to have disabled access, they have to be autistic friendly, lots and lots of categories they have to tick boxes and get the okay from the Clinical Care Quality Commission. And there's a new act coming in now with health and social care being integrated, and for children also adding education. So that's another big change, trying to work the two together, health and social care, which is difficult because those professionals don't like really talking to each other much. So a lot of change. So here are the boring pie charts, just to show you some outcomes. So 62% of patients reported improvements in feeling well, just generally, that week. This is post-group. This is in session 12. We also measure activity. They're asked to write an activity down that their symptoms prevent them doing, and then we'll also look at the scale, 0 to 5. This week, how well can you do that activity or not? 0 being I can't do it at all, 5 being I can do it really well. So it could be driving, it could be anything. So in terms of activity level, again, 56% improved in that. And then the overall symptom severity and activity and well-being, that's 81%, or 25 actually, improved in that. So we've got lots of improvement, which was really, really pleasing. Then the symptom distress, which was the real core of why they came, because they wanted to get rid of their symptoms. 65% reported an improvement in the experience of their symptoms. Some of them, as I say, the symptoms might have disappeared. Others continued having the symptoms, but they weren't so bad. It didn't affect them so badly. Depression, 81% reduced in their feelings of depression. Maybe because they felt better. Maybe because they weren't in such distress with their pain or their symptoms. Anxiety, 68.75% reduced in their levels of anxiety. These are all standardised tests used in the health service. This is the global functioning, the GAF 7, patients reported improvement in those. We had 81%. And then we also collected data about whether they went back to their GP or not, whether they went to secondary care or not, whether they improved in their usage of medication. They all wanted to be off medication. They hated being on medication. And also, hospital visits. So you can see the support they felt they were getting was increased post-group. Well, that's understandable considering they've been in a group for 12 seconds. Their medication reduced. Their GPs improved. They didn't go to the GPs much. The higher it is, sorry, I didn't explain this. The higher it is in percentage-wise, the less people went to their GP. So you can see 60-something percent, 68% or something, didn't go to their GP during the process of the group. So at least the GPs weren't so frustrated. And finally, hospital visits. Not many went to A&E either. And we're just finishing the post-group now analysis, where we look at all these figures again 6 months down the line to see what the changes are when they're not in the group, between post-group and follow-up. So that's just the percentage of the pre to post-group shown as patient numbers and percentages. So you can see those coming in at, as I just said, we're just a repeat. So you can see we use the PHQ-9, which is a scale for depression in primary care. The GAF, general functioning, global functioning. MIMOC, it's an interesting one that, developed by a nurse. Measure your own medical outcome profile. And it asks them to name up to 2 symptoms that affect them daily. And it also has well-being scores and functionality scores and symptom distress scores. And finally, the activity scores. So just very quickly on the follow-up, this is as far as we've got so far. So 6 months post-group, we had an analysis compared to the post-group improvements. Not only were sustained at 3 months, which was what happened in the pilot, but this time continued to be maintained at 6 months. And the areas were functioning, well-being, anxiety, depression, and symptom distress. So the 6-month post-group compared to the pre-group analysis showed an improvement or maintenance of their activity levels. That's one of the activities they labelled they couldn't do at the start, or very minimally, that they improved in that activity and they sustained that improvement over the next 6 months for 50%, so half of them. Well, even if only half get better, it's better than nobody, isn't it? Improved well-being. Again, 50% of people at post-group when compared to pre-group improved in their well-being. And improvement in social occupation overall functioning, 75% of people when compared to pre-group. So that was pre-group to post-group, not follow-up. This will do follow-up. And one of the things I say to GPs when I'm training them in medically unexplained symptoms, because they don't really know much about medically unexplained symptoms, so I do training. One of the things is that they want the patients to self-manage. They don't want to be managing them all the time. The whole kind of emphasis now is on self-managed care because it saves money. So what the GPs are trying to do is help patients to sort of do this a little bit more. Help patients to be more empowered, to take care of themselves more, not to go to A&E, because it's costly to go to A&E all the time. And to do that self-managed care, patients have got to have the inner resources. So in order to have those inner resources, they need to be promoted in terms of resilience, because that's what you need. If you're going to be resilient, you need to have the inner resources to draw on to bounce back. There's a ticket now. It's got that strong tail. So you've got to have those inner resources in order to bounce back and in order to get on with your life without being dependent on the health service. So as the patients became more capable and felt more in control, more capable of managing their symptoms within their lifestyle, with these are the changes, after a little while that becomes a habit, a different kind of habit. And once you've engendered that habit into their general life, then they can maintain that stability and they can go on to maintain resilience. So it's about cultivating a new habit. And the habit, I think, they don't know this, they don't say this, is the connection between body and mind. It's that habit. It's making it's helping them become aware all the time of what's going on in their bodies and listening to that to such depth that they're absorbed in it, to such a point where they can actually then respond to it adequately. I had a harrowing account from somebody the other day who was a fitness freak. She spent 10 years punishing her body, no pain, no gain. We know that from dance, don't we? No pain, no gain, punishing her body, gym every day, 3 times. Every day, 3 times a day. On the treadmill, on these cross trainers and all that sort of thing. And she was in pain. And her body was telling her, stop. She didn't listen. She went on and on and on. She can't move now. She's in so much physical pain, she cannot move. Because she never gave her body time off. She never let it relax. She never let it stop. She just pushed and pushed and pushed and pushed. And she knows now, looking back, but of course she's got this chronic condition, which has become habitual, finds it very, very difficult to change that. But those are the people we're aiming to help. So feelings of well-being then sustained over time will increase the resilience to cope when symptoms are experienced. And then feelings of empowerment. So this big word empowerment of our bodies, empowerment of ourselves, that's cultivated in order to help them to control their symptoms over time, leading to self-managed care and reduced dependence on the NHS, and thus saving money, basically. So just a few little comments from patients to read. So we do a little patient experience form at the end of the 12 sessions, asking them to rate, from referral through to the final assessment post-group, ask them to rate their experience. And we get a really, really good, excellent to very good satisfaction rating on all patients going through the programme. And this was some quotations from some commissioners who commissioned the service. And there's a few comments from GPs. One GP actually found my ex-directory phone number and phoned me up to say, thank you so much, this patient is never coming back again. Wonderful service. I don't know how you found my number, but GPs can do anything, can't they? Very powerful people. And there's some references. So we've got time for questions. That's the best bit.
I trained specifically
Yes.
to do a
Good
little bit more
question.
about the actual intervention?
Okay, so in order to facilitate one of these groups, you have to be trained at MA level for human psychotherapy or body psychotherapy, because they also have similar backgrounds. I will take psychotherapists who have been trained at MA level if they can demonstrate they've got a lot of practice in a particular physical form like yoga or dance or something. So they have to demonstrate to me that they can relate to their body. Okay? So that has to be in there. So that's the first thing. We also ask for 2 referees. They fill in a detailed application form, and then we have an interview of 2 days, which is a part 1 of the training, where we then invite people back to another 2 days if we think they're suitable to finish their training, so part 2 of the training, and then they complete that with an assessment. And then there's ongoing CBT every CBT. No, they don't get CBT. CPD, continuing professional development every year.
And the actual treatment itself?
So, one other thing in terms of eligibility, they have to have worked with adult patients in groups for a minimum of 5 years or equivalent. So we're looking for the most experienced practitioners. These are very complex patients, very complex. And we know from research done before that the main change process happens between the facilitator, or therapist, and the group. That's the main thing. They wouldn't accept that, the patients wouldn't accept that, but that is what it is. They really respond to the empathy and compassion delivered by the facilitator. So we do want people who are experienced in group work. They don't have to be experienced with patients with MUS, because we train them in that, but they do have to be well versed in group work with adults. The therapeutic approach, well, it's based on, as I say, authentic movement, body awareness, sensory motor experiences. It's a combination of various different things. It's a little bit of psychoeducation. We have a manual where it's all listed out with a typical session up to 4 in the first part, and then another 4 sessions, and then the final 4 sessions. And that, people don't go through it like a robot though. They respond to the group, you respond to the people in front of you. But there are certain things that we want to cover over those 12 sessions. And if you're going to do an RCT, you've got to have a manual. So we've got to be able to show that this facilitator in York is doing the same kind of group as this facilitator in Southampton. You know, there's got to be the comparability, which we'll have to check with video. We'll have to do snippets of video, observations, and check that they are sticking to the manual.
And when do you do this in a private space? Where do you do private?
Very good question. Yeah, not in a mental health establishment.
Yes.
Not in psychiatry, not in mental health,
Okay.
not even in community mental health.
Repeat the question.
Where's the setting? She's asking the setting.
Yes.
I interviewed all the patients who went through the pilot study about that and said, you know, where's the best? And they really like being at the university. They really like, we held it in the university first.
Oh.
The first pilot study, proof of concept study was held at the university. They loved going there. They were very happy with that. So we have held them at university since. But also community settings, like meeting places in the community, children's centres, local health centres, local alternative type health centres. So anywhere in the community near their GP practice, within spitting distance, and we've got to be public transport, obviously, because some of them can't drive. It needs to be accessible, it needs to be in the town. But having said that, we'll be talking to the ologies. Cardiology, neurology, rheumatology, gynecology, dental. 37% facial pain is unexplained. 37% of people coming with teeth problems, unexplained. They don't know what to do with them, these patients. The patients just send away, just go and live with it, you know. So a lot of referrals come from dental. But all these ologies in the hospital settings, again, it's not best practice. They've admitted that. They won't put it in writing, but they've admitted it's not best practice just to refer the patient back to the GP. There's nowhere for them to go. So they want a clinic in the hospital. So we're talking to them now about in the Lister Hospital in Hertfordshire, trying to set up a clinic where they just refer straight into the clinic as an outpatient. So it would be a room in a room in hospital.
1, 2.
Which they might be willing to go to. It's not psychiatry. Yes,
How big are the rooms?
maximum 10. Maximum. Minimum 5. So between 5 and 10. Yeah. Because if you have 5 or 6, if you have 5 people, one person's absent, you can just about manage with 4. It's a bit of a group. Might have 2 people absent, which is a little bit dicey, but if you can get 7, 8, 9, 10, it's much easier for somebody's absent to hold that group. It doesn't feel so fragile. But having said that, they're not absent. They might miss 1 session or 2, but that's it. They don't continue with the absent. They all want to go. They want to meet their friends.
Men and women?
Minimal men, token man. Most women somatise.
About the research itself.
Yeah.
So, I mean, we all understand this. It helps people to pay attention to their bodies, to get them in touch, to unite them.
To notice their bodies.
And
Other than what they already noticed, which is the symptom. It's going beyond the symptom.
So the outcomes are amazing. And so far. And I was just wondering about, do you think perhaps they're higher because these are test groups and there's a lot of attention that's being given to them? You know, they get loads of tests, you know, all these groups, you know, they've been tested, there's tests have been out. Would that be one of the criteria why the outcomes are higher? Because there's so much attention on them, you know, they looked after and asked again.
Sure, that's why we need a control group. But in the control group, we would still be testing. We'd still be using the same standardised measures with the control group at the same points in time, exactly the same points in time. So they would still have that type of attention. And anyway, it's good practice to measure pre and post interventions. It's just good practice. You know, we should all be doing that. We should all be measuring outcomes. Because otherwise we haven't got any evidence to validate what we're doing in our jobs. It's no good us saying, oh yes, it's really good, it really helps the patients, oh yes, and all the patients saying, oh yeah, it's really good, really like it. I mean, people are losing their jobs in the UK because they haven't got any outcomes. They've got nothing to show that actually what they do helps people. They're losing their jobs. Because everything is getting much, much tighter. You know, evidence is the key word. Evidence-based or practice-based evidence. Or evidence-based.
I understood you used validate tests to measure anxiety, depression, and not self-perception tests. And I would like, what's your opinion about this self-perception test? And do you think we can use in parallel with the other validate tests?
As I said, I get a patient experience form, which is all qualitative. And they talk a lot about their experience and how has it helped, been helpful, and I ask, you know, give us some feedback about how it's made you better. You know, and they all give, it's time consuming to analyse, but the qualitative stuff is there. It is there. Yeah.
Fantastic report and fantastic study. I'm also still wanting to hear if you are measuring the experience of the therapists.
Oh yeah, we did that.
BodyMind experience.
Yeah, we did that. Okay, yeah, it's not a study. This is practice-based. This is practice. This is practice. It's not a study. We haven't got a control group. We're following up people who, for whatever reason, had to go on holiday, you know, couldn't come on those days. We're following those people up, but of course it's a long process to follow up the odd 1 or 2 that don't come and measure there at the same time. It's a long job. But I do want to get an RCT underway if I can and get the funding. What's your question? That's right.
The therapists.
The therapists, yeah, we did. So in the proof of concept study, we asked the patients what they thought was going on in the sessions. So they described things that they remembered doing. And then we asked the facilitator to tell us what she thought she was doing in the sessions, because what we do and what we think we do are 2 different things, we know that. Anyway, then we analysed both of those questions, answers to those 2 questions, and we found there was very little difference between what the facilitator thought she was doing and what the patients thought they were doing. There was a lot of overlap, I wrote a paper about it, in fact. It's published in the Body, Movement and Dance in Psychotherapy journal. You know, the international ones. So, I think, and they've all been through the same training. They've all done the course, the training course to be facilitators, I think if we do this video analysis of people doing it in different places, I think we'll find there will be correlations between groups. But of course, it has to be something called a cluster analysis. So a statistician tells me I have to do a cluster analysis. So I have to find within group each group. So I have to have lots of groups and lots of different facilitators, and then there has to be within group outcomes, and then compare those across all the different facilitators. Do you understand? And then we'll be able to say, like the CBT people will say, what we do in York is the same as what we do in Southampton. It's the same. Then we've got something that's standardised.
Yeah.
Because you can't roll something out unless it's standardised. You can't just roll it out. Because different patients will get different things.
Thank you for your wonderful, inspiring presentation. I have two questions about the techniques used, one on authentic movement and one on mindfulness. Do you use mindfulness-based stress reduction techniques, and how do you use mindfulness in your work?
It's based on Kabat-Zinn's work, and Kabat-Zinn, and it's based on, because all of that stuff is getting huge following.
Yes.
There's a big research base for it. So we can ride on the back of that. You know, we're bodyfulness.
Bodyfulness.
Question I have on authentic movement. Do you use authentic movement in this kind of patient?
Yeah, all the patients use authentic movement. It's minimal. They're sitting in chairs. They might only be moving fingers, but they are using that technique. That was not a technique. It's a process, I think.
Yeah.
It's an intersubjective process between the facilitator and the mover. They're all doing it. And they embrace the creative body, in fact. You know, because they want to have a different experience. They want to do lots of relaxation and massage and things like that, because they think they'll feel better in their bodies. But actually, after doing the movement, they feel better, and they haven't had all that. We don't do relaxation techniques, or we do a little bit of self-massage as a warm-up, maybe, you know, just to kind of get them connected to the body self. But it's not the major. The major work is in this kinetic, mindful movement with the symptom in mind. That's the piece that we're working with all the time in the different practices. And we have different questions that we ask them, and then their response is whatever their response is. And then they get the feedback, and they speak about it, and then they get the witnessing offering back. And then they make sense of it, as we all do.
Thank you very much for this working, because I was in that way of thinking what to do with those clients who are in this way of functioning. And I was just thinking about that way. There were many results which were concerned about increasing, decreasing, and no results. But there was one thing, activity, no decrease. So they understand that something is happening with their activity, but they may not think about that it's connected with something else. And maybe it's the way of the kind, it's about the kind or the quality of reflection. How do they understand? Because you said 50%, it's better than
nothing. Yeah.
But I think it's the more, the results are better.
Yeah. This is
because it's about the reflection, their capacity to reflect.
And the habit. You see, I don't think in those 12 sessions a new habit has been formed yet. They have to practice that over the next 4 months. That has to be embodied. It has to be so embodied. It has to go on. It's one little tiny moment or a few moments in a session, but then that has to go on. So the noticing has to be embedded in their body, if you like. So I don't think necessarily the post group assessment is necessarily reflective of what happens 6 months down the line. So I agree with you. It was only 56% improved in their activity level, but even that is better than they were when they started.
Feeling better. Yeah.
Feeling that they
Feeling
want to
better.
support these
Living
results.
better.
Just to say that maybe experts' evaluation would help and would make this picture more.
Thank you very much. I think the interpretation of results is always very interesting. Because everybody's going to interpret them with their own glasses on. It could be that they didn't notice any difference yet in their activities post-group, not so much difference. But however, maybe later on, then it starts becoming more habitual. Things change ongoing.